Hi, this is Elliot Fishman, and welcome to part 3 of our lecture on hepatic masses. And we left off last time beginning to talk about hepatic hemangiomas. Now, hemangiomas are one of the more common lesions. They're important because they're always benign. In theory, large hemangiomas can spontaneously bleed or bleed with minor trauma, or bleed if you biopsy them. So it's very important to be able to recognize hemangiomas. When you have multi-phase acquisition, hemangiomas are a bit easier to recognize than when you have single-phase acquisitions, because hemangiomas have a variable timing in terms of enhancement. Some basic facts: they're more common in women, predominantly in the right lobe of the liver, but can occur anywhere. They're usually in the periphery of the liver, and in terms of a classic appearance, 90% of them are classic. Now, what do you mean by a classic appearance? Well, we mean that on the early phase images, the lesions have peripheral enhancement, and then if you get additional scans over time, the lesion fills in from a peripheral to central pattern. Now, in the old days, we used to say that a lesion had to fill in its entirety, and we carried the images out to 30 minutes. Now we recognize a lot of hemangiomas don't fill in their entirety because they often will have central scars. To me, and I remember there was a talk Mike Federle gave years ago that made the point the initial scan was everything, because once you see puddling, you make the diagnosis. Now, there's no doubt that you can see peripheral enhancement in primary hepatic malignancies or metastasis, but it's a puddling appearance. And in this case, you can see a little bit of the puddling. Now, I will admit, depending on the specific hemangioma, sometimes the puddling is at 30 seconds, sometimes is at 60 seconds better, sometimes 90 seconds. If you pick 60 seconds, that might be the best one. And you can see in terms of hemangiomas, many are small, but others are large, and those are sometimes more challenging. And we typically call a lesion a giant cavernous hemangioma when it's equal to or over 5 centimeters. You can see on the coronal view the puddling of the lesion. Now, the puddling is not 360 degrees. Sometimes it is, but as in this case, it doesn't need to be. When you look at the area around 3 o'clock, that's the best puddling in this specific patient. If you go about 30 seconds later, you can see the increase in the puddling. I do find that by using MIP imaging, you can see the puddling better. Think about it. If a hemangioma is a circle and you're getting peripheral enhancement, if you do a MIP image, it flattens everything out, so you really see the puddling a whole lot better. And here it is again. Now you're filling in more of the lesion. This is a pattern that you're not going to see with other tumors. It's not going to be seen with FNH. It's not going to be seen with hepatic adenoma. It's not going to be seen with primary malignancies or metastatic disease. And here is on the venous phase, you can see the puddling is getting more intense. You can see the areas of central scarring. We used to talk about how central scarring was classic for FNH, but you can see central scarring in hemangiomas, FNH, hepatic adenomas, as well as malignancies. Another patient, again, here's that puddling of the lesion, better shown when you look at the MIP imaging. Hemangiomas can be single or they can be multiple, and they can be variable in size. Another series showing you the MIP imaging, and as I mentioned, MIP can be very helpful, particularly on the larger lesions like this, but also in smaller lesions. Here we're out now about 70 seconds. You can see the puddling along the rim. And again, if you only had this image, I guess you could ask the question, could I be wondering if this was a necrotic primary liver tumor? I could be considering that, but that puddling is different with hemangioma. Now, I will say, if you're uncertain, just get an additional scan another 30 to 60 seconds later, and the lesion will continue to fill in a pattern classic for hemangioma. And here's just some more from that same case, very nicely showing you the very bright puddling filling in the lesion. Here it is with a cinematic rendering where the central lower density portion of the lesion is very well defined. Here's another case. This is 13 centimeters, large mass, and in fact there are multiple smaller lesions adjacent to the dominant mass present. Again, that peripheral puddling. The smaller lesions are nearly filling in their entirety very quickly, but this large mass, classic puddling, continues to fill in. This more central low density, very, very classic for hemangioma. And again, MIP imaging can be useful when you have challenges. Now, it's interesting, I mentioned most hemangiomas in the right lobe of the liver, and they're mainly within the liver parenchyma proper, often peripheral. This was a patient who was sent to us for a GIST tumor, and if you look at the lesion, the liver looks fine. Here's a GIST tumor coming off the stomach, because it looks like it's coming off the stomach, and that would be the look of a GIST tumor. Now, one of the things you need to pay attention to, it doesn't happen very often, and I've made this mistake a couple times, I don't make it anymore. When you look at this lesion, this may be coming off the left lobe of the liver, and when we gave contrast, you can see the peripheral puddling. And I remember reading this GIST tumor saying this peripheral puddling, and really what happened was, this is the left lobe of the liver, and this is a hemangioma, which is a polypoid exophytic lesion, and a typical appearance, but one that occurs, and it simulated a GIST tumor by pushing on the stomach. You can see classic hemangioma pattern. GIST tumors can be vascular, but they don't have this type of pattern. So again, this patient did have surgery. I remember looking at the path report, hemangioma. I thought it was a typo, and then they told me that my report had the typo on it. Here's another example. Again, maybe this is a mass coming off the stomach, but you see the peripheral enhancement. It's off the left lobe, lateral portion. There's the peripheral puddling. There's the feeding vessel into it. Very classic cavernous hemangioma. Here it is again. Again, you could think even on the cinematic, stomach, mass coming off the stomach. But again, occasionally, and I've seen this probably no more than a dozen times, you have this mass coming off the left lobe of the liver simulating a gastric tumor. So a really nice GIST as well. Now, we mentioned with perfusion changes. This case, you see a very bright lesion, which was hemangioma, and there's some perfusion changes around the lesion. And I showed you an example of this in my first talk. And I made the point that typically perfusion changes, you worry about vascular lesions that are often malignant. But you can see this lesion, the perfusion changes disappear quickly, and the lesion fills in from peripheral to central. It becomes isodense very quickly. This was a hemangioma. So I want to make the point that hemangiomas sometimes fill in very quickly. And it's a challenge, particularly with very small hemangiomas. They fill in quickly, and you wonder, could this be a metastatic neuroendocrine tumor? So it can be somewhat of a challenge. Again, feeding vessels to hemangioma are typically small. And again, this case is a difficult one because it fills in quickly and has perfusion changes around it, but can be challenging. Now, we typically don't think about hemangiomas calcifying, and this was a patient who was staging colon cancer. There's a mass in the right lobe of the liver with dense central calcification, and my first thought that this was malignancy. Colon cancer are often mucinous tumors. Mucinous tumors can calcify. When you look at this lesion, there's maybe no real peripheral enhancement. There's that central calcification, and this patient went to surgery. This was resected. Fortunately for the patient, this was not metastatic colon cancer, which what I would be thinking about every single time. Rather, what this case was a sclerosed hemangioma. A very uncommon lesion is a sclerosed hemangioma. It's a hemangioma that basically infarcts centrally and often has dense calcification. It's a great mimic of other tumors, be it a metastatic colon cancer or even theoretically a hepatoma. The thing about the sclerosing hemangioma, it's a benign lesion, but typically that diagnosis is made on biopsy or surgical resection. In this article by Yugawa, hepatic sclerosing hemangioma, a rare benign lesion characterized by fibrosis and hyalinization, occurring in association with degeneration of a hepatic cavernous hemangioma. Such atypical hemangiomas can be diagnosed incorrectly as primary or metastatic malignancies. Again, this is what happened in our case. Now, I'm not sure what I could tell you that would help you make the diagnosis. The lesions typically don't enhance much. They have dense calcification. But if I showed you the last case, and I'll go back to it one more time, I still would have read this as metastatic colon cancer. But it's a really, really good pitfall. And again, in this article by Yugawa, making the point how rare these lesions are, 2 in 1,000 autopsies. So very, very rare. So it can be a challenging case. Now, the next thing I want to speak about is focal nodular hyperplasia. Another classic benign lesion, female predominance, is usually an incidental finding. Over 80% are incidental, 20% are symptomatic, and that's when they get very large. And these lesions have no malignant potential. Theoretically, they can spontaneously bleed, but I've at best seen one case. The thing about FNH, it can look like hemangioma, and so you would then consider it benign. But if you don't understand what FNH looks like, you can confuse it with malignant tumors. So that becomes very, very important. And this article by Bergio, it's an incidental finding in asymptomatic patients, and distinction between FNH and other hypervascular liver lesions, such as hepatoma or metastasis, is critical. And again, it can be somewhat challenging. But I think when you look carefully at these lesions, you're not going to have a problem making the diagnosis. So it's typically an incidental finding. And the thing about them is they become very isodense very quickly. Look at this 6 centimeter lesion right lobe of the liver. Within 30 seconds is gone. You can see a little bit of mass effect, just the veins, but the lesion is basically gone. Now, it doesn't look like hemangioma on the original scan. Could it be a hepatoma? Could it be hepatic adenoma? Both those lesions can become somewhat isodense, but not the speed of FNH, and there's no evidence of cirrhosis. You almost never see FNH in a cirrhotic liver. Another example has a 4 centimeter mass that's totally gone. If you only had venous phase imaging in this patient, you never would have seen the lesion. Another example, a larger one, hypervascular but homogeneous. One of the key things this case shows, when you have the brightness of FNH, it's typically as bright as the IVC, but never as bright as the aorta. Hepatomas, hepatic adenomas, even occasionally hemangiomas, are as bright as the IVC, but even more bright than the IVC. They're closer to the aorta, where FNH is typically going to be the IVC. Here is another image. FNH, I originally described that in my first article as a scar, and that was classic for FNH. I would say it's common with FNH. Often the scar is fibrosis and doesn't fill in. But as I mentioned before, many lesions can have scars, and you can see this lesion is becoming isodense because it was large, the mass effect on the hepatic veins, and the central scar remains. So thinking about it, FNH, non-contrast can be iso or hyperattenuating. Arterial phase, it's hypervascular, and if you do MIP, often has a feeding vessel toward the central scar. And on venous phase imaging, it fills in. Now, it's not always going to fill in or become isodense totally at 70 to 90 seconds. It may take 3 or 4 minutes, but you can make the call at 70 to 90 seconds. Another example, bright lesion, big, central scar as bright as the IVC, and there's a second lesion next to it, which also ends up being an FNH. Here's another example, non-contrast scan. the liver looks normal. Look at that 5-centimeter vascular lesion, central scar in the right lobe of the liver. You can see there is no neovascularity. There is no underlying cirrhosis. And as you look at this lesion, over time, as you go to venous phase, the lesion nearly becomes totally isodense. It goes from here to here, nearly totally isodense, central scar, very classic for focal nodular hyperplasia. And here's several additional late phase imaging. Another example, again, big mass, central scar. If you look at the MIP imaging, you can see there's a vessel coming here, which goes right to the center of the lesion. I find that if you do MIP imaging on FNH, you often can see this small vessel. It doesn't have the irregularity of a malignancy. It goes right to the center of that patient's mass, and that's classic for focal nodular hyperplasia. Again, look at the brightness, the well-defined borders of the lesion. The enhancement is homogeneous. This is going to be the look of focal nodular hyperplasia. You can see some smaller vessels within the lesion present. And then as you go later, the lesion now is becoming nearly isodense by 70 seconds. The central scar, which may never fill in, typically doesn't, well defined. So think about the differential. No, it's not hemangioma. I'll show you in a moment, it's not hepatic adenoma, and it's not hepatoma, and it's not metastasis. This is the classic look of FNH. Now, FNH has variable vascularity. There are always vascular lesions, but some have a bit more prominent vessels than others. So you can see a little bit of the stretching of the adjacent liver by the patient's primary mass. And again, when I look at this, the appearance, the scar, the homogeneous enhancement, the intensity looking like the IVC, I don't need to think, I don't need to biopsy, I don't need comparison or follow-up studies. This is a benign lesion. It's focal nodular hyperplasia. And again, look at it from the early to the later phase. Look how nicely it fills in. And again, the filling in is different than hemangioma, which has that peripheral to central filling in. So again, let's put this case up. And you can see as you go to delayed phase, with an imagination, you could see the lesion in retrospect. But imagine you having a 6-centimeter or 7-centimeter mass that becomes nearly isodense in under 5 minutes. Very classic for FNH. So key differential diagnosis points. It enhances to the level of the IVC, never to the aorta level. You can see feeding vessels to the central portion of the lesion by the central scar. The central scar, which is vascular, sometimes on arterial phase imaging, can become isodense, and you may or may not see it, but again, that classic scar was our original description of FNH, and the lesion becomes isodense on later phase imaging. Now, every one of the cases I just showed you, the FNH was within the liver proper, but like that hemangioma I showed you before, occasionally these can become pedunculated lesions, and when they are, they can be challenging. And I'll show you a couple examples. One thing to mention is that FNH can occur in malignant patients and simulate malignancies. This was a patient with renal cell routine follow-up, has some fatty infiltration of the liver, and a large mass that was initially interpreted as metastatic renal cell, because renal cell to liver are typically vascular lesions, though I have to admit they're not this large and they're often multiple. But here's a large vascular lesion with a central scar. You can see how large this is on the coronal view. You can see some of the vascularity, but it's really the vessels of the hepatic artery that are being pushed by the mass effect. You can see some small vessels centrally within the lesion. And if you look at it about 70 seconds, central scar, looks like the case we just saw. Central scar, low density, slight vessel displacement. It has mass effect, but the lesion has become isodense. You can see the hepatic veins in the right lobe of the liver, but this mass is pushing the veins. It's not invading the veins. It's not occluding the veins. It's simply giving you really nice mass effect. And again, as you go later, that central scar. I show this case because you can see how difficult and how confusing it is. You have a renal cell. You're worrying about vascular mets to the liver. You see a vascular mass, but then when you analyze it, you recognize you're dealing with FNH. This was eventually biopsied and was proven to be focal nodular hyperplasia. And you could see by about 5 minutes out, the lesion is totally isodense, and the only thing you see present is that scar in the tumor. So a really challenging case of FNH. Here's another challenging case. This was felt to be hepatoma. There's a mass that's denser than the liver. It's not very vascular compared to the aorta or IVC. We even thought perhaps this was a perihepatic mass. When you look carefully at the venous, the lesion is isodense with a scar, but it's pedunculated. You can see that it's fed by the hepatic artery. And again, this was initially read as a pancreatic mass or a peripancreatic or perihepatic lesion. This patient had biopsy and eventually had surgery, and that was FNH being pedunculated, a really good case. Now, when I talk about FNH, I have to mention hepatic adenoma because same group of patients and can look very similar. But I see we're kind of running out of time. Let's stop here and let's come back and pick up and talk about hepatic adenomas. So with that, see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.